Hello viewers, welcome to another episode of Healthy India. And today we're going to talk about something that all of you are thinking about all the time and talking about all the time, and that is Omicron. And there is so much wrong information floating around, so much new information. We've got the best experts in the country to sort it all out for you. Let's learn more about Omicron. Before we go ahead, let's understand what are viruses. Viruses and bacteria are actually infective agents that can affect us in various ways. But how are bacteria and viruses different? And why is it important to understand? At the common level, it's not unusual at all for people to take antibiotics because their cold wasn't responding. Without realizing that the common cold is caused by a virus and not by a bacteria. So if one treats bacteria by antibiotics, one may actually be producing resistance if there is actually no bacteria and you're treating a virus. So we do not try to treat viruses by antibiotics. Viruses and bacteria are different agents. Bacteria are single-celled agents that multiply in nature, that live in our body. In fact, the total number of microbes we live with is sometimes said to be tenfold more than the number of cells in our body. Viruses, on the other hand, can only grow and multiply when they have a host, so within a host cell. And that's an important difference. So viruses outside any host are relatively inanimate and they're not really doing much. But when they get into a host cell, then they multiply and they can actually affect and damage the whole host cell in a multitude of ways, including just killing the cell or converting it into a tumor. So there's a lot of difference between bacteria and viruses, both of which are important agents for us to understand. And what we are talking about today, as I said initially, Omicron is all about virus and a variant of the virus. To discuss much more about this in detail about Omicron today, we have a panel of illustrious experts. We have Dr. Gagandeep Kang, who's professor of microbiology at the CMC Vellore and is one of the leading experts in India and internationally in this field, has contributed a lot by her research in virology, in particular with regard to the COVID pandemic. Of course, she's also known as a rotavirus person, but definitely in terms of our understanding and approach to the COVID-19 pandemic, she has been one of the key figures on the national scene. And we have Dr. Anurag Agarwal, who is the director, CSIR Institute of Genomics and Integrated Biology. Again, a pulmonologist by training, but who's interested very much in the basic science of respiratory viruses. And we are very happy to have both of you here. And Dr. Khilnani, who you heard in great detail recently about sleep disorders, an expert in clinical pulmonary medicine. At present, he's of course, the chair of the PSRI Pulmonary Medicine and Sleep Medicine Department. But before this, he was the chief of pulmonary and sleep medicine at the All India Institute of Medical Sciences in New Delhi. So we have a pretty illustrious panel for you to discuss all these issues. I was talking about viruses, and we all have learned the word corona, which actually means crown. And corona is a large group of viruses. Coronaviruses is a very large group and includes some of those that cause things like common cold, but we also know some of them have been known to cause the SARS, the SARS, the severe acute respiratory syndrome in 2002, an epidemic that shook the world, followed by the Middle East respiratory virus in 2012. Again, that had a huge impact globally. But of course, this was all outdone ultimately by what we saw in 2019, when we faced the SARS-CoV-2 virus, severe acute respiratory syndrome, coronavirus 2. And then, of course, we reached Delta, and now we are talking of Omicron. So the first question to you, Dr. Kang, is, why does this keep happening? Why does the virus just keep quiet? Why does it keep mutating? Is it to exist? Is it to survive? Is it to thrive? What is it?
So there continue to be debates about whether viruses are alive or not. but viruses certainly are capable of replication. And for any organism that replicates, one of the things that you want to do is to be able to continue to replicate. And if humans build up immune responses that can completely shut down viral replication, then that's not good for the virus. So the virus tries to use strategies that it can. I'm treating it like a sentient being, which it isn't. But viruses then try to evolve to escape the immune response and sometimes to be able to spread into more than one species. There are a number of ways by which viruses can generate the genetic diversity that is required for them to continue to multiply. One of those ways is by having mutations or changes in the genetic code. There are also many other ways by which viruses evolve. There is recombination, there's the generation of diversity through incorporating retroviruses, but the one that we are most concerned with right now is mutation. Mutations happen much more frequently in RNA viruses than they do in DNA viruses. And that's because when you make a copy, you tend to have proofreading mechanisms that are much more widespread in DNA viruses, less common in RNA viruses. But in fact, the sarbecoviruses, SARS-CoV-2, does have a proofreading mechanism. So when we talk even about mutations in RNA viruses, SARS-CoV-2 evolves quite slowly compared to other RNA viruses. Bottom line, it's all about survival and multiplication.
But then we also know that, Dr. Agarwal, that many viruses, they just mutate and become ineffective. Ineffective meaning not pathogenic to humans or to animals. And some of them, when they mutate, they go on becoming worse in terms of their pathogenicity. So what is a variant of concern? When we say this is a variant of concern, there's so many variants that have already been described for the SARS-CoV-2. So what actually is a variant of concern?
So a variant of concern can be understood in three very distinct ways. In the very first way, you can imagine a variant that is more infective, able to transmit very, very fast. You can imagine a variant of concern that leads to severe disease. And you can imagine a variant that changes the epidemiology course. For example, everybody is vaccinated. This new variant can break through all the vaccines and again cause a surge of the pandemic when the pandemic appears to be coming down. That alone, that deterioration of epidemiology, is also a variant of concern. So when we look at these kind of characteristics, we have seen that viruses change. As Dr. Kang said it, the virus is fundamentally not necessarily even alive. It's inert the way you used it, but it knows how to replicate. I don't imagine that how much disease is caused to the human is a particular determinant as long as the virus can continue to replicate and transmit. So in general, over a very long time, you will find that a virus will optimize itself for transmission, not for severity. But there are many possible random walks it can take towards that path. Sometimes it becomes more virulent. Sometimes it becomes less virulent. Sometimes it becomes more virulent, less able to transmit, and the pandemic ends. Sometimes it can do both, more virulent, more transmissible. But in the long term, it tends to become more transmissible, able to evade immunity, able to maintain replication, but doesn't really become very, very severe.
So, Dr. Kang, how do you see the path of SARS-CoV-2? How is that panning out? We started off with SARS-CoV-2, and then we've had a sort of series of variants. Some have gone one way, some have gone the other. Would you just very briefly take us through that path of SARS-CoV-2?
If we look at the history of what has been happening with SARS-CoV-2, we started with the virus emerging from Wuhan, which was very quickly replaced by another virus that was known as D614G. This was actually the original mutant, the first variant of concern, but at that time we didn't classify it as a variant of concern. This one spread around the world, and we started then to see variants that were being identified as people sequenced viruses around the world, but they didn't have major functional consequences and were not shown to be of concern epidemiologically until we saw what was the UK variant in November, December of 2020. This is the variant we now know as Alpha. It spread around the world. It came to India very quickly and started to spread, particularly in North and Western India, until it was very rapidly replaced by what we now know as the Delta variant. The Delta variant traveled from India across the world, and the Delta variant is still causing disease in many parts of the world. But along with Delta, we are seeing the Omicron variant, which is so far the most transmissible of the variants, which is spreading very rapidly across the world. We've had other variants as before, some classified as variants of concern, like the Beta variant. These were ones that were able to escape the immune response quite well, but did not spread. So there was some degree of local spread to the Middle East and other places from South Africa, but it didn't become a globally dominant strain. Similarly, we had Gamma in Brazil, and that also did not travel too far afield.
So, Dr. Agarwal, coming back to you, everyone's talking about Omicron now. 2019-20 added, COVID and Corona to a common man's vocabulary. 2021 added Delta. Everyone knows Delta across the world. And now, at the cusp of 2022, we have a new word, Omicron. And this is like, as Dr. Kang explained, this is the way the virus has evolved, or rather mutated, not really evolved, into different forms. So what's so special about this Omicron?
Right. I mean, apart
in terms
from
of its structure, yeah.
Absolutely. Apart from teaching us all Greek alphabets, what has happened with Omicron is it has acquired a lot of mutations. Now, why are these mutations important? We understood a little while ago that the virus induces an immune response. And in the SARS-CoV-2, there is a protein called the spike protein that primarily uses to enter the cell. And various points on this protein, antibodies can bind. At least 4 major sites have been identified where antibodies can bind. So when the sequence of Omicron first came out, it was obvious to everybody who was working with the protein structure of the spike protein and the binding of antibodies, every major site of antibody binding to neutralize the virus had shown mutations. Structurally, it became very obvious that antibodies raised against previous variants capable of neutralizing those variants from entering cells and replicating would be much less effective against Omicron. So from the very structural molecular information, it was clear that it was over 30 mutations, some of which expected to aid transmission like the N501Y, the P681, and many of them expected to prevent antibody binding. We were looking at a variant of possible concern. And obviously, when it came out, we could see in South Africa, reinfections were very quickly rising. That proved it was able to evade immunity, and that made the call much, much easier. But this ability to evade immunity, far greater than anything we have seen before, and an innate transmissibility, which matches or exceeds Delta because of some critical mutations, together makes it the fastest growing variant so far, with a huge transmission advantage over Delta.
It has a huge transmission advantage over Delta. But in terms of severity of disease that was seen with Delta versus Omicron, and we'll come to that in detail later, Would you say that Delta has been the most sort of severe out of the variants in terms of severe disease causation? Or it's the mix of transmissibility and various things put together that causes that?
So estimates of severity by necessity come from known cases. And in different studies yield different numbers. It is clear that Omicron seems to be less severe than previous variants. Whether Delta was by far the worst is harder to say, but Delta was clearly a variant with preserved or increased severity and increased transmissibility and some immune escape. So the potential to cause large outbreaks and deaths may have reached a peak with Delta. Omicron spreads clearly much, much faster, but we are in a post-Delta world with higher natural immunity, higher vaccination, some degree of innate reduction in severity. So I do expect that we will see less deaths.
So, Dr. Khilnani, you managed a lot of patients during Delta times, and we're all, again, managing patients of Omicron. Can you make the statement that disease with Delta was clearly more severe than we are seeing with Omicron, and it was also more severe than the wave before that? Was that a feeling in the clinical setting?
So I could actually comment on wave 1, wave 2, and wave 3. One wave, we saw wave 1 when we had zero vaccinations. There were severe disease, there were deaths. We had very little knowledge about the treatment that we were doing. Over the time, we came to know steroids were useful, antivirals were being tried, still there were mortalities. By the time the Delta came, part of the world was vaccinated. Like if you talk about India, the healthcare workers were already vaccinated. But despite that, to my mind, Dr. Anurag was a little skeptical about committing himself, but I'll commit. As a clinician, we saw that the Delta wave, the patients had more severe disease. Delta was definitely more contagious. I thought that from the clinical standpoint, if I use the judgment, the incubation period was very short. The spread was very fast. The severity was very high, and so was the mortality. So quickly coming to the Omicron, which I have been seeing now, and I presume that what I'm seeing patients these days are 84% in Delhi are Omicron, so I can comment upon that. Now today, what patients that I'm seeing, of course, I don't have sequencing data of the patients that I'm seeing, but these patients are actually presenting with only stuffy nose, scratchy throat, little bit of body ache, maybe at best fever for 1 or 2 days or 3 days, and it subsides on its own. As you, Ambrish, commented that if you give antibiotics or you don't give antibiotics, people think that antibiotics are working. And these people are responding within 2 to 3 days' time. I have not seen any patient who has complained of shortness of breath or have low saturation or a severe chest pain or even severe cough for that matter. So the news seems to be good with Omicron as compared to the Delta or the Alpha variant, which have been talked about. The first and second waves were devastating. This particular wave, which has already come in with community transmission, seems to be very, very mild for the time being, but only time will tell when the numbers will go up. As the US is seeing a large hospital admissions, as the UK is seeing significant number of hospital admissions, what will happen in India as the numbers are escalating? I'm not able to comment on that, but we have to be very careful as we comment on that. Thank you.
Thank you very much. We'll take a short break and be back with you soon with much more information about Omicron. Well, thank you, Dr. Khilnani, and I actually second your observation. All my patients with diabetes and endocrine disorders who are calling in, getting affected, getting positive, some of them are a little sicker than very mild, but yes, none of them evoke the images of Delta so far. No one's getting pneumonias. For me, that's the biggest thing, that no one's, oxygen is dropping. They're not getting pneumonia, but it's early days yet, and we're just seeing the beginning of this surge. So let's see where it leads. Dr. Kang, what is the impact of prior infections? I mean, how much of the Omicron change in clinical profile is determined by the fact that we faced all this as we have, as Anurag pointed out, and we all know? How much of it is, I mean, I say Omicron is a bad virus, maybe, and because we've all been exposed, maybe that's why we're getting mild disease. What do you say about that?
I wish I could give you a quantitative answer, but I can't. So the best I can do is a more qualitative answer, and that is to say that Omicron is certainly more capable of causing reinfections than any virus we have seen so far. The infections appear to be happening in people who have had prior infection or prior vaccination, or a combination of prior infection and vaccination. So just in terms of infections, Omicron is clearly capable of infecting on a background of infection, vaccination, or both. But in terms of disease, we don't have quite as much of a handle as we would like to have, because we know that hybrid immunity is likely to be best. Vaccination plus infection will protect best against severe disease. But right now, we don't really have the numbers from anywhere to give us clear answers that would be applicable to India. There are hints from the data from South Africa, some of the data from the UK that is particularly helpful, but I think we can't say for sure how much of the prior infection contributes to protection from disease for Omicron.
Back to you, Anurag, and what is the impact of vaccination? Gagandeep mentioned about impact of infection and vaccination. Where would you put the vaccinations as modifying the clinical trajectory and the presentation of Omicron?
I think the best data we have right now in quantitative terms comes from the UK. And if you look at the UK data and you look at adjusted odds ratios, you find the most protective against symptomatic infections was prior known infection. Then came vaccines. But what was very important was 2 doses of almost any vaccine. It didn't really matter mRNA or AstraZeneca, Covishield, or anything else. Gave barely any protection against infection, but continued to protect against severe disease and hospitalization. But even when I say that, the UK data also showed that protection against hospitalization compared to 90% plus in the past seemed to be falling. It was falling depending upon how far you were from the second dose. So as you went further and further out, the protection did decline. It remained good, 60% or so, but it was not the 80, 90s that we were used to seeing earlier. A third dose of vaccines in UK, irrespective of the background vaccine, AstraZeneca or Pfizer, did lead to rise in protection. So it seems to help in protecting against severe disease as well. So in a summary, I would say, don't expect 2 doses of current vaccines to protect you from infection. It will reduce symptoms, reduce severity. A third dose may reduce it even more for the high-risk population. And which third dose is still not very, very clear. But that is a topic that I'm sure Gagandeep can speak more on later.
Well, actually, I was going to qualify your third dose protection by pointing out that that study has very short follow-up time.
Correct.
So what you're seeing as very high rates of protection is a very short period, and we don't know how long that will be maintained.
Absolutely. In fact,
some people have suggested that maybe 10 weeks even.
Yeah.
There's a paper saying that even after the third shot, it may start declining very soon again. So it's like a never-ending saga, of course. But we're talking of clinical infections. Yes.
Can I come in there?
Yes.
Well, I think we are doing vaccines and prior infection a disservice. I think we are rushing to boosters without completely understanding how much protection healthy people have from prior vaccination or infection. And then we create a situation where you can't get the data you need to inform longer intervals because you've already boosted everybody that's likely to participate in such studies. So this is a very peculiar situation to be in as a vaccinologist, where we are rushing to give boosters without understanding what the best booster is, what the best timing for the booster is.
But in a more clinical setting, if we could see surges coming on and some evidence that giving a third shot, whatever you call it, precaution dose or booster or whatever, a third shot did seem to reduce the risk of severe disease in several studies. And of course, I'm not talking of just antibody generation, which obviously you will say is not important on its own, but even disease. So when, as a public health professional or as a clinician, when that surge, you're facing that surge, and you at the particular point don't have a real shortage of vaccines, and you at least are probably fairly confident that you will not do any harm by giving a third shot, then perhaps it becomes an even more difficult decision to take at that point, whether to go ahead or not to go ahead. And which is why I suppose many countries went ahead, and countries like Israel are giving fourth shots for whatever it means, So I guess that's a very, very difficult question to answer. And one has to go by whatever is the overall situation in that country, in that population, in that region, to take a final call. But the kind of data that would really answer those questions is going to be very, very hard to obtain now. That's my feeling. I don't know how you would get that granular data that you would require for answering the question that you did, unless you do a systematic study in different kinds of populations. What do you say, Dr. Kang?
Well, actually, Israel isn't doing a systematic study. They're just using their entire country as a laboratory divided into 4 parts. The UK is doing a lot of systematic studies, but they are all dependent on data that is being collected largely nationwide. And then there are some specific studies that follow cohorts. So it's not impossible. And with all of the data that is being collected in India, if those databases could be joined up to each other, we could answer many of the questions that we are trying to answer. Basically, you have your testing database, you have your clinical information, and you have your vaccination information and the data that INSACOG provides. So 4 sets of data. And if those 4 sets of data talk to each other, every single question that we have about how the vaccines are performing, how infection is protecting against specific variants in this country can be answered.
Thank you. And Dr. Khilnani, have you had any unvaccinated patients that you've treated with Omicron so far? I haven't had any. All the people I've dealt with have been vaccinated.
I haven't had any unvaccinated, but I've seen people who are infected before and had 2 dosages of vaccine, and now have got COVID infection, presumably Omicron, And of course, all the cases that I've seen have been at least vaccinated fully, both with either with Covishield or Covaxin, even with Pfizer vaccine, those who were staying abroad before and came. And so I can talk about that, but I don't have any database to tell you. I can give you only my impressions about that. And this is only short period that I've seen some cases in detail, and all are, of course, I don't see them physically these days for obvious reasons. But I've already described the profile of these patients. I haven't seen a single case who has lost its smell or taste. I haven't seen anybody desaturating. I haven't seen anybody terribly ill, except for sort of moderate grade fever. Nasal stuffiness and scratchy throat seems to be the hallmark of Omicron. But that's not so specific, but all my patients start complaining of only that at the outset. And I'm sure if we are detecting one, there are 9 which are not detected at all, because the symptoms are so mild that they are not being, that they don't go for testing. This could be because of the unavailability of tests. This could also be because of the person feels that it's not important. Thank you.
A lot of people are not going for tests because they consider it a common cold, and we'll come to that point again. But this bears out what we are seeing in early days in India, bears out what worldwide people have seen in the early period of the Omicron wave, and also sort of ties up with laboratory and other experiments that showed that this variant preferentially multiplies in the throat and the bronchial tree, and not so much in the lung tissue itself. Doesn't typically cause consolidation or lung damage. And maybe that's going to be the biggest difference between this and the earlier variants. And, moment you have lung damage, you have consolidation, and then oxygen dropping, then steroids, and the whole thing starts. And then maybe remdesivir at that last year, and then mucormycosis. I mean, I really hope we don't go down that path, and whatever Omicron is remains above our lungs, in our bronchial tree and throat and nose and that area. So quite clearly that seems to be.
I'd like to say something before going into any sense of euphoria. One should be very skeptical about it. The Alpha variant, when it came, we thought it was contagious, but was mild illness, and it showed its colors later on. So it's too early to declare it that it doesn't go into the lung. There's a huge population which is immunocompromised, elderly. Only time will tell how it behaves clinically. Thank you.
I totally agree with you. The fact is also there that even initially in Delta, at least, we were seeing significant lung involvement and oxygen drops. So fingers crossed, and let's hope it moves in the right direction.
Maybe I can one more thing.
One question before the break from you. Yes, please.
So the data that many people use to say it doesn't grow in the lung is a comparative study between Delta ancestral Omicron and lung cells and bronchial epithelial cells.
Yes.
What that study actually shows, and our institute is a collaborator in that paper, is that compared to Delta and ancestral, Omicron grows faster in bronchial epithelial cells and slower in lung epithelial cells. But if you give it 72 hours, all of them grow quite well. So if fast dissolving illness, less peripheral lung involvement, you expect to see, but kind of as Dr. Khilnani said, as you will get to a more vulnerable section of population, previously uninfected, which is a small category in India anyway, not yet immunized, which is also becoming a small category, thankfully, you might see more lung disease than has been seen so far. And that is the best explanation we have right now for desaturating children requiring oxygen in many countries, because that was the last remaining uninfected, unvaccinated category. And while they are naturally preserved from severe disease and death, you do see quite a few of those cases being reported in many other countries. So I think sometime before we relax,
Yes, totally agree. I'm not at all suggesting that we relax. I'm just being hopeful. It's really early days and we don't know how the numbers are going to pan out ultimately. Now, Dr. Kang, we are getting this infection. Omicron is all over. Will it, and maybe it's milder, even though it spreads very, very rapidly. Will it help us in the future in any way? I mean, there's a whole talk of natural vaccine, and we have to counter that every day in our own ways. What is your thought about that? Maybe this spreads everywhere, and we build our immune defenses so well that the next VOC will not be able to attack us so badly. What do you say to that?
Well, there are some interesting data that indicate that if you have antibodies to Omicron, they neutralize Delta quite well. So you get a broader immune response with Omicron infection than you do with Delta. So that is interesting because that makes Omicron a very potentially valuable vaccine candidate. We started with vaccines that have worked very well, but those vaccines were based on the ancestral Wuhan strain. And we are already concerned about whether those vaccines are giving us the broadest and longest lasting protection that we could potentially have through vaccination. It's very possible that Omicron may be a strain that allows us to make vaccines that give us a broader immune response. It has already so many mutations that have resulted in changes in spike structure that it covers a lot of ground when it comes to thinking about an antibody response that may be broadly protected. So whether Omicron circulating around the world is a good thing or not, I definitely don't think that any virus circulating around the world is a good thing as long as there are unprotected populations and unprotected individuals within protected populations. So a vaccine, fine. Infection for everybody, not a good thing.
Thank you, Dr. Kang. And again, we'll take a short break and be back with you soon with our last segment and more information about Omicron.
Hello friends, the next episode of Economic Sutra is going to be about the Central Vista project. As you can see, I am right here on Rajpath where preparations are being made for Republic Day. I will also be interviewing architect Bimal Patel about the wider project.
The project has multiple objectives. It's meant to improve infrastructure for governance. It's meant to improve the prime public space of Delhi. It's meant to protect heritage. So improving this public space was a prime objective of this project. By giving it simple facilities and upgrading it in many ways, toilets and pathways and the lawns needed, sprinklers, simple stuff like that.
So see you all there on Sansad TV.
Welcome back after the break. And in this segment, we'll focus largely on the clinical presentation and treatment of this Omicron wave. We've learned a lot about the Omicron virus, how it evolved from the SARS-CoV-2 virus, how it seems to be highly infectious, spreads very fast, but perhaps at the moment does not seem to be producing severe disease in immunocompetent individuals. And time will tell us more. I'll come back to Dr. Khilnani now, who has rich clinical experience in managing COVID-19 cases. You already told us the clinical features. Now, someone is coming to you with those clinical features, which are cough, maybe nasal, even a runny nose. I've seen runny nose or nasal stuffiness, body aches. Some of them have severe body aches, fever. What should one do? okay, I think I've got these symptoms. What I come to you, what do you advise me?
So, Amrish, as we have learned over a period of time, what is the aim of treating uh, COVID infection? Aim of treatment, one is that you want to save the patient. Second is you want to reduce the transmission of the disease. And since we have treated wave 1 and wave 2, and we have burnt our fingers, we started using hydroxychloroquine, we started storing it, people were storing it in their houses, in the cupboards, that will save our lives. Azithromycin, ivermectin, and doxycycline. As the studies came, none of the diseases worked. And then as the disease severity increased, our ICUs got full. Our aim was saving lives, those who were potential to die. So we were depending on drugs like remdesivir. Remdesivir should not be given to mild cases, should be given only in severe cases. We learned that steroids were very useful. Then came plasma therapy, which was also dumped, and then came anti-IL-6 medications like tocilizumab, and that really helped. Now the focus is that we have reached a plateau. I am not talking about ICU care, ventilatory care, non-invasive ventilation, and high flow nasal cannula. That's not the focus. Now currently focus is at two. One is prevention in the form of vaccination that we have discussed in somewhat detail. And what questions that you have asked me, that what is the clinician's aim? When a patient comes to me with a positive report of COVID-19 within 5 days of illness, my aim is provide him comfort. That's the minor part. That's very easy with analgesics and whatever you want to do. My aim is that it should not culminate into severe disease. By that, I am trying to prevent the mortality. So patient should not be requiring hospitalization, person should not be requiring oxygenation, should not go on ventilator. To do that, there are two things which have come up. One is monoclonal antibodies, which have found place in practice, and these monoclonal antibodies are not a blanket thing, which can be given. The same antibodies which are prepared for Delta variant or Beta variant cannot be given to the patient who is infected with Omicron, for obvious reasons, which two experts can divulge on that. However, the antiviral drugs, of which only remdesivir was approved for serious disease, now we have a couple of antiviral drugs, namely molnupiravir and Paxlovid. These are the two antiviral drugs which are recently approved. Molnupiravir is approved by DCGI India also. What they do is that they reduce the chances of hospitalization and death to the tune of 50%. And there are no large studies, but some of the reasonably well conducted studies, obviously they are funded by the industry, but these are published in one of the best journals in the world, New England Journal of Medicine. So these are the medicines which can be used to reduce the chances of severe disease, but with the rider. That these studies were conducted in people who were 60 plus or who had comorbidities like obesity, hypertension, diabetes, CAD, and so on and so forth, must not be generalized to give it to everybody. So one should be judiciously using these drugs, use it when well in time, and only the time will tell how effective they were, because the previously used drugs were dumped. But I think in today's time, judicious use of monoclonal antibodies and early use of antiviral drugs which have come now, that includes remdesivir also, but remdesivir is an injectable drug, cannot be given to all people. This is actually a silver line in the current treatment. As far as the treatment of the severe cases is concerned, they are well standardized, and I don't think this is the time and forum to talk about it. But about 55% of these patients had Delta infection and also other alpha, beta, and mu variants. So there is no reason to think that it will not be effective against Omicron. That's the way I'll put it. Thank you.
So a question for Dr. Kang is, that I meet somebody who's positive, or someone in my family or close circle, or my colleague at work, he turns positive or she turns positive. And I was with that person all day yesterday. What should I do?
Rely on rapid tests.
Rely on rapid tests?
Well,
so
I think caution is always good when you have been in contact with people who are positive. It obviously depends on the duration and the type of contact. But if you are thinking that you are at risk, using rapid tests, I think, is an excellent way of moving forward to ensure that you are not putting other people at risk. Now, in terms of the kinds of settings where we work in our hospital, for example, we also take into consideration vaccination history of the person who is a contact. Because one, you don't want them to get sick, but you also don't want them to transmit. So in order to check whether that person is transmitting, you can ask them to test at 5 or 7 days. And then based on the results of that test, give them advice on what interactions they can have following that. Assuming that they are negative, I think 5 days if you are someone not in a healthcare setting, 7 days if you're someone in a healthcare setting with a negative test should be fine.
So you are relying on antigen testing a fair bit to decide infectivity.
In the hospital, we don't rely on the antigen test at all. We use an RT-PCR test. And the advantage of using an RT-PCR test when you have a schedule like this, your contact was 5 days ago, so you know when you are supposed to get a test, or your contact was a week ago, when you're supposed to get the test. I'm talking about rapid antigen tests being one step on top of that to tell you in case you become infectious earlier than that. So I'll give you an example. Suppose you want to go visit someone in hospital who currently has cancer and is on treatment. Well, if you've had an exposure, you can choose not to go. If it's absolutely essential that you go, then do a rapid antigen test, and at least with reasonable certainty that you're not going to be infectious when you go there.
And all of us are happy with the rapid antigen tests that are available to us. Is there any difference?
The quality of the tests has improved significantly with time. The early tests that we had were really rubbish. But
that's exactly why I'm asking. Yeah.
There are some good tests available now. And if you're using a good test, then that's fine. I think one of the things that we really should do is have criteria and rankings for what constitutes a good test. And unfortunately, there has been little transparency around that. We've had pass or fail or reports given without necessarily having what, from a laboratory point of view, I would think would need to be a constantly updated panel used for evaluation of tests.
So we are running out of time, but I have a few points which are very important. And one is that if today I get a cough and cold, should I get a test done? Should I get an RT-PCR done immediately and decide whether I have COVID or not? Or since most of us are recovering anyway, we should refrain from that. Anurag, what's your take on that?
Tough one, but I'll answer it the usual way. There are people in this weather, for example, if I would take myself with a history of asthma, not every cough or a sneeze will make me running for an antigen test. At the same time, if it was my nearly 8-year-old mother starting to show fever, cough, cold, forget fever, just cough, cold is unusual for her, I would almost certainly in today's time want to get a confirmation, or there's a decision making to be done. If it is in the middle of this, forthcoming wave, it's here. And, the testing is difficult. And my young daughter who has exposure gets the same cough and cold. And again, she doesn't have the background. I would probably put her in isolation, wait for a few days and have her come out with some kind of a testing if possible, preferably an antigen test. So different situations, different things you would do based on prior clinical probabilities and decision points that you may have to make based upon the test.
So my concern in this has always been that either we agree that all URIs, and I'm just coming, all URIs require isolation, or all URI upper respiratory infection, जो जुकाम खांसी हम लोग बोलते हैं कि जिसको जुकाम खांसी हो वो आइसोलेट कर जाए 5 या 7 दिन के लिए, और या फिर ये हम कह रहे हैं कि सबका टेस्ट हो. दोनों में एक चीज तो करना पड़ेगा, या तो सबका टेस्ट हो और फिर डिसाइड करें कौन आइसोलेट हो रहा है, और या फिर सब आइसोलेट हो, अदरवाइज तो ऐसे ही फैलता रहेगा.
I think the minute you have fever into the mix, so one distinguishing factor between a cough and a URI tends to be the whether or not you have any fever or not.
Yes.
So the minute you put fever into the mix, you are more towards a clear URI type of a situation. And then you would either have to choose isolation without testing, or you have to choose testing before you mingle with people. One of the two.
So Dr. Khilnani,
So what I was saying that, the isolation is not a very easy thing. We all have had occasion. I have had an occasion to isolate myself during the first wave when I was sort of exposed to, and it's not easy. So what I'm coming to is that decision to test, there are several other factors which will determine. If it was 2 months back in Delhi, city of Delhi, if somebody had got a cold, I would not ask him to test because the chances of positivity were very low. As on today, anybody presenting with new onset without any prior history of scratchy throat or running nose, feeling along with little bit of headache or feeling low or feeling dull or body ache, feeling cold, even without documented fever, I would suggest a test, whether rapid antigen test or a PCR test. This is because not only it is his risk, this is a risk to his fellows, this is a risk to his elderly at home. He must know his status. We have not yet come to a stage where our testing system is overwhelmed. So I'm slightly differing with my colleague, Dr. Anurag, to just put a person for isolation. It's not very easy to isolate even. So therefore, it is important to know. Otherwise, if we don't test these patients, only after a person is tested positive, he will go for a serious isolation. Let me, as a clinician, I would like to tell you on a suspicion, just because you are having a bit of cough and sore throat, and if you are asked to isolate, people are not going to isolate themselves. So therefore, my take would be that in today's time, when the positivity rate is significantly high, which I know, everyone who is symptomatic must be tested so that he is clear what he has to do so that he doesn't transmit the disease. The rate of transmission, slowing the rate of transmission is a very big epidemiological tool in controlling this disease. Thank you.
Yeah, I mean, so far I'm asking everyone to test. Everyone who's complaining of any upper respiratory symptoms, I've been asking them to test, and many of them have actually turned out positive. Anybody wants to pitch in?
As far as I know the data on that one, the mutations are very striking. Again, very sensitive of immune escape, contains at least a few mutations for transmissibility and 501Y again. But actual clinical data for infectiousness, it's not yet there.
It's not there.
That's what I know. So we'll have to, as usual, wait for more information. And that's it.
So basically what I was trying to close with is the fact that we need to understand and appreciate the amount of work that scientists, researchers, scholars, doctors have done over the last 2 years to battle this pandemic, which is threatening to engulf all of us. Thank you very much again. Provided great inputs, very valuable points, and I hope all of us will be wiser about COVID-19, Omicron, a rapidly evolving area. Thank you very much. Thank you, viewers, for staying with us.